Hello, friends. So I'll be giving an overview on this contemporary topic, changing definition of ARDS. How relevant are they? So this topic was very cleverly given to me by Kritik, and I had to deliberate on this on 1st December. So as you see, so this can be a contemporary topic, and we need to look into what are the different definitions that has evolved over last maybe 40 years in ARDS and what is the latest with regards to the definition that is evolving, and is there a need for these definitions? I think this is what we will deliberate. So when you look into historical definitions of ARDS, how it has evolved, the first reference to ARDS came at around 1967. So it's by Ashbog et al. So that was the first time when this condition of ARDS was coined in 1967 by Ashbog et al. And until 1988, there was not much change. So in 1988, they introduced this lung injury score. So we'll speak about it. What are the components of lung injury score? And we used to follow that when I was training. We used to look into this as one of the entity. And after this, then there was a US and European consensus statement, which came in 1992 to redefine this. So this came at around 1992. So we'll talk about. So this is what we were sort of following until the Berlin definition came. So then 2012, this Berlin definition by ARDS definition task force came in 2012. So this is what we largely sort of accepted and were following. So prior to this, we were following the European and US European consensus sort of a statement or definition on ARDS. Now, 2024, so there is a move towards introducing a new global definition for ARDS. So this has been the timelines of how the definition has evolved. So we will look into what sort of definitions prevailed and what is the current understanding as to how we should define ARDS. So now the question we need to ask is why should we have this changing definitions of ARDS? So why we need change? Because when we say defining any particular condition, it has to be consistent in its ability and it has to be accurate in identifying the patients with that particular condition. And all these patients which are identified by that definition should have similar characteristics. And that is the main reason why we need that, because this enables one to conduct sort of a research from the clinical parlance and conduct research from epidemiological standpoint with regards to the burden of that particular condition, and for global networking and global sort of a data sharing. So these are the reasons why we need a proper definition so that all this cohort of these patients with a similar condition are captured and they are analyzed and they're looked into. And why this is needed? This is needed to understand the pathogenesis of the disease and to come up with treatment algorithms or protocols and innovative sort of a therapies for such conditions, and to synthesize the results of trials done across the globe and to look into outcome prognostication. So these are the reasons why we need proper definition and why the definition has to be robust in identifying these characteristics to do this to understand the disease process. So this is the reason why we need definitions. So we'll speak about, so Auersbach came in 1967. After that, lung injury score came. So this came at around 1988. So Murray et al. Came up with lung injury score. And this lung injury score consisted of three sort of a domains. So it consisted of risk factors, and it did consist of acuity of the problem, and it did encompass the severity of the condition. So what are the components of Murray score, which we were following? So they look at radiological sort of an imaging. So and they scored it from 0 to 4. So they graded as 4 when 4 quadrants of the lungs were involved. They graded as 3 when 3 quadrants were involved, 2 when 2 quadrants were involved. Then they looked at PaO2, FiO2, which is a typical sort of a parameter we look in ARDS. So more than or equal to 300 was considered 0, which is no ARDS, and less than or 100 was considered severe ARDS. And pretty much we have agreed upon this sort of a PaO2 by FPF ratios. Even to date, we call less than 100 as severe ARDS. Then they looked at the PEEP levels. So if it is less than PEEP, I mean less than 5, it is possibly no ARDS. and severe if PEEP has gone up to more than 15. So this was quite a nice, robust lung injury score where they have incorporated the risk factors, acuity, and the severity of the ARDS. And then they've looked at the compliance aspect also. So if it is more than or equal to 80, there's no ARDS. And if it is less than or equal to 29, then it is severe ARDS. And so are the other numbers in between. So this was the lung injury sort of stratification of severity of ARDS. So this was in 1988. Then in 1994 came the American European consensus sort of a definition of ARDS. So here they characterized two groups. They created acute lung injury and ARDS. I'm sure many of the trainees or my colleagues who may have been listening, we used to use this word acute lung injury very often prior to the Berlin definition. So they characterized as acute, and the acuity was acute in both ALI and ARDS. So PF ratio, it was simplified. Less than 300, they called it as acute lung injury. Less than 200, they called it as ARDS. And lung X-ray, a lung injury score looked into different quadrants, but American European consensus sort of a definition said, as long as they have bilateral diffuse alveolar based or interstitial infiltrates, you can call it as ALI or ARDS. And most importantly, the new aspect that was not there in lung injury score, which got added on in this, was presence of high filling pressure. So they had to look at absence of left atrial hypertension, which means the cardiac component as causing pulmonary edema should not be there. So there should not be any increase in the left atrial pressure, or on those days they were using pulmonary artery catheter. Now it's obsolete. So the wedge pressure had to be less than 18. So now I'm sure most trainees, we do the filling pressure by doing tissue Doppler by looking into the left atrial pressure. If left atrial pressure is normal, so which means you are ruling out the cardiac component of pulmonary edema in the lung. So you can call it as ARDS. So it was a very simplified version compared to lung injury score. And this is something we were following when I was in Australia. We used to follow this to the T, and we used to call ALI if it's less than 300, ARDS. But there were a lot of limitations. So what were the limitations of these? So the acuity of this problem was ill-defined. And see, here they didn't, although you saw the lung injury score took the PEEP into consideration. But here, AECC did not take PEEP into consideration. So, and this sort of a PaO2, FiO2 could be manipulated by PEEP. If you give high PEEP, so this less than 200 may become better. So on and so forth. So the PEEP was not factored in, and with PEEP manipulation, PF ratios could be changed. And I'll show you some of the studies that looked into the flaws of this definition. And interpretation of this bilateral diffuse alveolar interstitial infiltrates was unreliable, and it could be subjective. And this wedge pressure, isolated wedge pressure or filling pressure, is fairly oscillatory. So not necessarily it will be consistently high above 18 millimeter. You may have only one reading above 18, and you may label it as cardiogenic pulmonary edema, and it will take away the ARDS from the picture. So these are the fallacies. And sometimes there could be false elevation of this left atrial pressure. So these were some of the limitations of this AECC. And the acute lung injury was used inconsistently in someone who did not fit into ARDS. So these were some of the limitations. And if you see the studies, so this study came in 2003 by Argentinian group. So they took 48 patients with ARDS who fitted into AECC criteria. And here, after 6 hours of PEEP, you see 52% of these 48 patients had PF more than 200, which means initially, which were labeled as ARDS, by manipulation of the PEEP, they did not qualify as ARDS. And after 24 hours of PEEP, 62% had PF ratio of more than 200, which means by manipulation of the PEEP, you could take away from the cohort of labeling someone as ARDS. So this was the limitations. And this was in a Canadian paper which came in 2002, where 82%, which means most of these patients had one reading of left atrial pressure more than 18. And after that, some of them did not have. So which means there was a lot of overlap. So which means any patients with the diffuse alveolar infiltrates, predominantly many of them had one reading more than 18 millimeter and which were labeled as cardiac, although they might have had ARDS. So these were some of the fallacies of this AECC definition. So that was about 1988 lung injury. 1992 we got AECC. Then came the Berlin's definition in 2012. So what is the Berlin definition said? So Berlin definition emphasized on the timing, that development of hypoxemia within 1 week after the onset of insult. That insult can be pneumonia or extrapulmonary cause like pancreatitis or trauma, blood transfusion, so on and so forth. Or the worsening of respiratory symptoms should happen within 1 week. So after the onset of the trigger, in 1 week, there should have been the progression of the symptoms. And radiologically, is the Berlin's definition, they should have diffuse bilateral alveolar infiltrates. But Berlin definition said they should not have effusions, nodules, or underlying lung disease. So why I'm emphasizing this is because the new global definition says even though they have underlying nodules or they may have collapsed due to some underlying chronic conditions, they can still have ARDS. So this eliminates that possibility. If they have underlying other background lung conditions, it says you cannot label. So that was one of the limitations of this Berlin definition. And Berlin definition put emphasis on echo evaluation of heart failure. Because if you see the previous AECC, it relied on pulmonary capillary wedge pressure more than 18, and it said there should not be LA hypertension. Here, it only says you have to do echo evaluation and rule out the cardiogenic cause of heart failure. And like the previous definitions, PaO2, FiO2 was taken, but here they factored in PEEP, because if you see the AECC did not take PEEP into consideration, and that could have been manipulated by applying PEEP. Here they said any mild, moderate, severe, if you have to call this ARDS, they should have been on PEEP more than or equal to 5. If on PEEP, if PaO2 FiO2 is less than 300, you call it mild. On PEEP more than or equal to 5, if it is less than 200, you call moderate, less than 100. So again, similar to lung injury score of Murray's, but they have added PEEP into this, that it is related to the, even with PEEP, if they remain hypoxemic, to call it as ARDS. But what are the limitations of Berlin definition? Berlin definition does not take into consideration, if ABG is not available, it is very hard because it does not take saturation as one of the one of the entity that you could utilize. In the absence of ABG, it is hard to utilize Berlin's definition. Why I'm emphasizing is the new global definition takes saturation as correlative of PaO2. I will talk about it. And another important limitation, after Florali trial came, because many of the ARDS, even in COVID, we know that we used to use HFNO. And this Berlin definition says either patient should be intubated or mechanical ventilated, or there should be an NIV, because you're talking about PEEP of more than 5. So it does not take into consideration HFNO. So if patient is on HFNO, we cannot utilize the definition of Berlin definition. And in resource limited settings, sometimes there may not be radiology department. So here there is de-emphasis on lung ultrasound to determine sort of a pulmonary edema. And it relies only on X-ray, ABG, and NIV or mechanical ventilation. So these are, and in resource limited, these facilities may not be available, where you may have to use only saturation, or you may have to use lung ultrasound and not necessarily depend on radiology. So these were some of the limitations of Berlin's definition. So there were other limitations. So there is no sort of a cardiogenic marker for the pulmonary edema. And the single PaO2 by FiO2 at diagnosis can sometimes be a poor performance, because you take one ABG and you look at the PaO2, FiO2, but serially you may do it much later on. So at diagnosis, you'll be labeling someone as moderate or severe ARDS. So there is no continuum of oxygen as a reflective of what sort of categorization of ARDS you are meant to do. This is an important aspect. So lung mechanics were not taken into consideration, like dead space ventilation divided by tidal volume, which is more reflective of the lung involvement, is missing in the definition and prognosis. And PEEP less than 5 is generally inconceivable in any ARDS. Another important limitation is in ARDS, all the current definitions are only taking about the lung inflammation. But very often we know there are other organ failures that are prevailing. So we need to have some definition which encompasses whether it is only single organ failure with ARDS or other organ failures are involved. And it does not give emphasis on pulmonary sort of a circulation or a pulmonary sort of a microthrombi that may be formed, so on and so forth. This is not involved. And there is no, we very often know in ARDS, pulmonary hypertension and the RV function gets affected. So these things are not factored in any of the definitions of ARDS. And now, most importantly, we are recognizing different phenotypes of ARDS. So categorization and subphenotyping is not there in any of the ARDS definitions that have happened so far. And the phenotypes is based on ventilation of dead space and tidal volume. And phenotypes are based on severity of endothelial injury, and severity is based on biomarkers. And these things are not included. And now there is more emphasis on personalized sort of a calibration of PEEP optimization to the patient. So patient-specific personalization of mechanical ventilation based on etiology, based on lung physiology, based on imaging, and based on clinical subclasses is what has been emphasized. And these are also not part of any of the definitions that has evolved in here. So these are all the general limitations of definitions that have evolved over 30 to 40 years in ARDS. So these limitations still prevail at this point of time, because the definitions, whatever we have, does not encompass all these other nuances which we are trying to adhere to, the phenotypic nuances and calibrating to the patient's needs or customizing the ventilation to the patient needs. So that is something which is not part of any of the definitions so far. Now coming to the meat of this talk, what is the new global definition that has come? So that there are new diagnostic criteria for the new global definition that has come in 2024, and there is a move towards getting this validated. So that's why we are talking on this. So the new global definition should encompass the nature of the ARDS. So ARDS, so you have a pneumonia, and then this pneumonia leads to inflammation in the lung that leads to ARDS. And this ARDS can be due to extrapulmonary causes like polytrauma. It may be due to burns. It may be due to transfusion, or it may be due to aspiration. So these are, so the new global definition, the move is to incorporate other causes of ARDS and not necessarily confined to pneumonia as the cause. And then the definition should encompass the pathological processes that are involved in ARDS, which is a lot of alveolar capillary disruption and inflammatory exudates that tend to happen, leading to flooding of the alveoli, which leads to hypoxemia and reduced compliance. So all this has to be part of the new global definition. And global definition of ARDS should also include the therapeutic modalities, which is prone ventilation and adequate sedation, analgesia, maintaining fluid balance, and PEEP optimization. So basically, the premise for new global definition is to encompass the therapeutic aspects, the pathophysiological aspects, and all the etiological aspects of ARDS. So this particular move towards global definition of ARDS came in 2024, published in AJRCC. It is not validated, that there is a move towards validating this definition. So just comparing to the Berlin's definition says the worsening of respiratory symptoms or the trigger to the onset of ARDS should be 1 week. So if you look, just focus on the right side of the column, which is the proposal for new global definition. So the new global definition says condition should be precipitated by an acute predisposing risk factor. So which means there can be a chronic element on the background, but you have to, any acute one that has caused worsening of the chronic can also be taken as for etiological aspect of ARDS. And look at the left one is a Berlin, bilateral opacities on chest imaging, which said X-ray or CT. But the new global definition says ultrasound can be utilized, lung ultrasound. There is emphasis on utilization of lung ultrasound to determine bilateral opacities as whether fluid or ARDS, as is what has been incorporated in the global definition. And this is important. So in the previous Berlin definition, it says the pulmonary edema should be non-cardiogenic. But the new global definition says there can be both components. There can be cardiac aspect, but along with it, there may be infective. This is something very important. Increasingly, we are seeing many influencers who come with ARDS. They also have cardiac component. We do echo, filling pressures will be high. We drive, we give diuretics, we dry them, and then the underlying sort of a lung component gets manifested. So basically, it says they may have cardiac component underlying. So once that is ruled out, if there is an underlying infective component leading to ARDS, you can still call it as ARDS. So they can coexist is what the global definition emphasizes. And look at the left side. So this was the categorization of the Berlin definition of ARDS. I want you to focus on the right side. So the global definition includes saturation and SF ratio. We used to look at PaO2 and ABG divided by FiO2 as a ratio. The global definition says even you can take saturation and FiO2 ratio, and these are the ranges. It's slightly more than the mild is 200 to 300, here 235 to 315. Remember 315. Moderate saturation and FiO2 ratio, it's less than 200. Here it is little more than 200, 148 to 235. Severe, it is less than 100. Saturation by FiO2 ratio should be less than 140. So the global definition says you don't need to rely on ABT. Even if you have saturation, that is good enough. So you can take saturation by. So this is a major move from the Berlin's definition that you can utilize lung ultrasound, cardiac component can be present. The Berlin's definition said they cannot have underlying nodules, underlying collapse, or underlying sort of a lung condition. But the new definition says they can have underlying condition. On top of it, if they have worsening, you can still call them as ARDS. And cardiac component and non-cardiac component both can coexist. So these are the major changes towards global definition. And in non-intubated patients, very importantly, the Berlin definition said they have to be on a PEEP of more than 5, but here it says even if they're an HFNO of more than 30 liters, you can take that into consideration to define ARDS. In resource limited, PEEP and flow rate may not be needed. So PEEP is sort of de-emphasized. Even if they are in HFNO, you can still, if saturation by FiO2 ratio is less than 315, you can call them as ARDS. So these are the major changes need to be validated. So there is a move towards recognizing this definition. So basically, the new definition says saturation by FiO2 is correlative to PaO2 by FiO2, and saturation by FiO2 has a good performance if saturation is less than 97%. It avoids frequent ABGs, and this emphasizes on dead space and tidal volume as a marker of severity. If there is increase in the dead space ventilation, it is shown to have a good correlation with mortality. And the move towards global definition is also to emphasize on phenotyping of the ARDS to try and identify patients who are resistive to treatment and have clear targets to recognize the patients where aggressive and innovative treatment can be utilized, identify the patients who benefit from intubation or identify patients who benefit only from NIV bar HFNO and exclude patients who should not be part of the trial. So this is the sort of understanding that we have from the global definition. Just to give the definition, how global definition of ARDS proposed in 2024 is helpful with a case example. So this is a typical 68-year-old male with abdominal pain, septic shock, and acute hypoxemic. So this is a garden variety. You have bilateral lung infiltrates, patient on FiO2 50%, PF is 150. So he is intubated, and you can apply Berlin definition. It comes as moderate ARDS because its PF ratio is 150. But the new definition, so you have this lady, 54-year-old lady with history of breast cancer, and who's had a COVID pneumonia and worsening shortness of breath for the past 6 days. But patient is not on NIV. Patient is on HFNO, 40 liters. So more than 30 liters, you can call it as ARDS. And where you have not done ABG, you have only looked at saturation by SF ratio, 114. And patient is non-intubated. So this defines as ARDS. And so this is how you can utilize the global definition because you don't need PaO2. You have looked at saturation by FN and it constitutes as severe ARDS. And here is a 39-year-old female with abdominal sepsis and gram-negative bacteria in a under-resourced hospital without blood gas. They don't have chest X-ray, no mechanical ventilator, but you have used lung ultrasound to look at all these B lines or B predominant profile. And saturation is 85, SF ratio is 142. You can still call it as ARDS because here you have not used X-ray and you don't have NIV. But here you have used saturation by SF ratio and you have used lung ultrasound, which is indicative of infiltrates. You can still call it as ARDS as per the new global definition. So that is how there is a benefit or advantage of new global definition, identifying and recognizing patients not necessarily who are on ventilator, not necessarily who have undergone CT bar X-ray. So the proposed sort of a components of defining ARDS is compared to this bullet train with the 5 elements, 6 elements. So the first is try to identify etiological disorder and treat the etiological factor or the trigger. And the second aspect is adopt protective mechanical ventilation very early on, prone ventilation, protective lung, PEEP optimization, adequate sedation, analgesia, and neuromuscular blocker, and assess the severity by using imaging, dead space ventilation, and tidal volume biomarker. And they emphasize on assessing lung severity and systemic severity, whether lactates are high, whether Apache is high, SOFA is high, and try to utilize biomarkers to understand the systemic severity of the condition. And stratifying the disease based on the phenotypic, identifying patients who are resistant to treatment, and targeting specific patients where aggressive and innovative treatments can be used, so on and so forth. And other innovative therapies like ECMO, fluid balance, and NIV, identifying the group of patients who benefit from these should be incorporated. And outcomes, there is an emphasis on looking at short-term outcome, which is 7 days and 30 days outcome, looking at long-term outcome, and excluding patients who cannot be part of the trial. So this is the holistic sort of a components that should be a part of the definition is what is being looked at as a future in ARDS. So that's about it, folks. So you can submit your valuable work to our Journal of Acute Care, which comes out every 3 months. You can visit my website, www.drpradeeprangappa.com, to rehear to this lecture. So thank you. Thank you, Vandal.